Hello, everyone. Welcome back to BAP. I'm here with Toby Pillinger. Do you want to say hi and introduce yourself?
Of course. Hello, everyone. My name's Toby Pillinger. I'm a clinical lecturer at King's College London, the Institute of Psychiatry. I'm both a psychiatrist and a researcher interested in the physical health of people with serious mental illness.
Thank you so much for joining us. You've done this big piece of work. Tell us about it.
Absolutely. Side effects of antidepressants are common. They happen more often than not. I think it's estimated about 75% of people who are prescribed an antidepressant will experience at least one side effect. And there's an increasing onus as us as prescribers to really think about those side effects when we make prescribing decisions. The complicating factor in this process is that you need to be armed with the data in terms of which antidepressants you give are at greater risk of causing certain side effects compared to others in order to inform your patient as to which treatment might be better suited to them. With that in mind, we've embarked on a piece of work which is called a network meta-analysis that looks to rank antidepressants on how bad they cause physiological side effects. What is a physiological side effect? That's changes in body weight, blood pressure, changes in mineral levels like sodium, how your heart works, your liver functions, your kidney functions. And what is a network meta-analysis? So a network meta-analysis allows you to compare treatments against each other, which in the real world, those studies may never actually have been done. So in the statistical world, it allows you to compare treatments against each other. And at the end of this process, it gives you a league table of treatments from best to worst, which ranks those treatments for each of those given side effects that you're worried about.
So I'm going to ask you a really nerdy information science question, first of all, because I'm an information scientist. I'm a bit of a nerd. I remember when André did that massive antidepressant review a few years ago, landmark study, huge network meta-analysis over, hundreds of thousands of people in there, biggest one ever in mental health. What was interesting to me about that was that it was so important that they found the unpublished stuff, that they contacted all the companies, all the authors, get stuff out your filing cabinets. And maybe half of the stuff they had in the review in the end was unpublished. Yeah. So what have you done in that regard?
It's a really important question. It's a real, as you're saying, this is the key thing, because there is the concern, obviously, that there is bias in these publications where and we hope people don't do this, but the concern is that if a company gets a bad result from their clinical trial, that they may not publish those data points. Now, André, as you're saying, what we've done is we've tried to get hold of all of that grey literature, as they call it, the stuff that may not have been published in journals, not only contacting drug companies and authors, but also going to reports that companies submit to those bodies in America and Europe and the UK when it comes to getting these drugs licensed. So FDA reports, for example. And often the data that companies submit for FDA approval isn't actually published data. So getting hold of those reports and using those data points. And so, yes, we've certainly been doing a lot of that. It is a thankless task, and I want to give a shout out to one of the co-authors. Well, he's joint leading this project with me, Atishana Rumahan, who's been doing a lot of work here and trying to collect all of those data points. Just as something to flag up, though, because the data that we are extracting is change in all of these sort of physiological parameters, I think there is maybe a little bit of less of a concern about bias in terms of the presenting of this data, because often these were secondary outcomes that drug companies maybe weren't quite so worried about in terms of them being published. So we hope that won't be as much of an issue as companies maybe not presenting data in terms of how good these treatments are for the actual treatment of symptoms of depression. But it is a really important thing that we're trying to address in this project.
So it's always difficult when you've got such a lot of data and you're trying to work out how to summarize it and present it to the world. I guess I'm interested in just the basic data about the side effects of different antidepressants and how those kind of profiles work. And that's not necessarily that available in the literature currently. What have you discovered?
Yeah, you're absolutely right. The data just isn't out there at the moment. And we did a piece of work last year that looked to create a side effect database for antidepressants and actually also antipsychotics that could inform personalized prescribing using a digital tool. And part of that process was to look for all of these previously published network meta-analysis to inform those side effect databases. But they just didn't exist for antidepressants. So that's was really one of the inspirations behind doing this project. And in terms of the key headline results here, and I'm wary that there is such a lot of data that I don't want to overwhelm people at home, the real key headline is that it's pretty hard to find an antidepressant that doesn't have some form of physiological effect. And that's not surprising, really. A lot of the receptors, the neurotransmitter systems that are in the brain, are all over the body. Our hearts are studded with all of those receptor systems that our brain are as well, as are our kidneys, as are our livers. So it is not surprising. And the other thing to bear in mind is that this was a study that looked at the acute treatment with antidepressants. So usually these studies ran for about 6 to 8 weeks. And you want to keep that in mind because often people take these treatments for much longer than a couple of months. And so physiological effects that happen over a 2-month period may be different in 12 months, 24 months. And so that's something we need to bear in mind. One of the key findings for me, actually, a real headline, was the differences in the effect that these drugs have on our heart rates. Really big differences across treatments. So on one end of the spectrum, you have, and these are quite old-fashioned drugs called tricyclic antidepressants, which don't tend to be prescribed as much nowadays. So drugs like amitriptyline that people might know about. This is a treatment that, on average, over a sort of 6 to 8 week period, will increase your heart rate by about 10 beats per minute, which is a large difference. And then at the other end of the spectrum, we've got drugs that are reducing your heart rate by about 10 beats per minute. So that is a huge differential of 20 beats per minute. And I think if you are a male and you're aged over 50, every single heartbeat, as your heart rate goes up by 1 beat per minute, your risk of mortality increases by 3%. So not only are these statistically significant findings, I would argue that they are clinically significant. And if you ascribe to the philosophy that you only have a certain number of beats in your heart, then if you're taking these treatments for 1 year, 2 years, 5 years, these are millions of beats extra, potentially, that these treatments are associated with. Now, we're making a number of assumptions there, saying that these are the consistent findings over a period of time, but I would argue that's a really key, interesting point. Another interesting finding was that the majority of treatments that we looked at were associated with weight loss, which is interesting because observational studies that have been published to date, looking at people over time using GP data, registry data, have shown that treatment with antidepressants is associated with weight gain. Now, of course, there is confounding by indication here because people who are treated with antidepressants, often the majority of people there will be struggling with their mood, which in its own right is associated with weight gain. So the question there is actually, is it the antidepressant that's causing this, or is it the illness itself? So that was an interesting finding. Now, there were treatments that were associated with weight gain that we do see in clinical practice. Again, those old-fashioned drugs like tricyclic antidepressants, amitriptyline, but also mirtazapine, which has a well-recognized weight gain profile. So people on average gain about 2 kilograms of weight with those treatments over a 6-week period, whereas on the other end of the spectrum, you're losing about 2 kilograms of weight. So I think that's a really interesting finding as well. Finally, other sort of key points, we showed that, broadly speaking, sodium levels didn't change that much with antidepressant treatment. Why am I interested in that? From a medical school, you're taught that antidepressants, in particular SSRIs, drugs like sertraline, fluoxetine, are a risk factor for low sodium. Your sodium drops. But actually, we showed that the sodium levels weren't too bad. There was a modest decrease with a couple of antidepressants, but broadly speaking, no changes. And why do we think we see that? I think it's because the people who are recruited to these studies are pretty healthy. And actually, it's when you're a little bit older, when you've got other drugs on board alongside a drug such as fluoxetine, then your sodium levels drop. And I think that's an interesting key take-home message. So yeah, very difficult to find drugs that aren't associated with physiological alterations. And I think there are implications for how we choose antidepressants in that context.
So I'm really interested in what we do with this, because I guess personalized psychiatry is the vision here. And ultimately what you're trying to do is give somebody an antidepressant that's going to work in terms of side effects profile. Maybe somebody in their 50s with a heart problem is not going to get one of those antidepressants that is going to cause problems with their heart, for example. Tell us a little bit about how you're going to use this, how you see this moving forward.
So as I mentioned earlier, we've already completed a body of work which looked to create a side effect database for antidepressants. And aligned with that, we actually published in the Lancet Psychiatry last year the development of a digital tool which looks to harness that database. And then the digital tool allows you to navigate that database to provide a personalized league tables of treatments from best to worst based on the side effects concerns of the individual. So I might be worried that I want to really avoid weight gain, and I also want to avoid feeling sick with a treatment. And sometimes antidepressants can cause sexual side effects as well. So if I've experienced that in the past, I really want to avoid that. But I might have different concern ratings for those different things. I really want to avoid weight gain, whereas I'm not quite so worried about the other two side effects. So you can put in those side effects, the different concern ratings, and then Psymatik allows you to integrate those concerns ratings with the database, which this work will inform as well, to produce that personalized league table. And we're really excited about this body of work because it is, for the first time actually, addressing a key onus that regulatory bodies are nice of in telling us to do, which is to consider side effects of psychotropics when you're making prescribing decisions and involving the patient, the person who's going to be prescribed this medication, in that prescribing process. And this, for the first time, we would argue, allows you to do that.
Really innovative implementation and really robust science. So congratulations and all power to you.
Thank you very much, André.